Now let's begin with the next part of transplant immunology. And we all know that this is a part not only which is an examiner's favorite, but not so with the students, because it's pretty difficult and we all have a problem in understanding all the rejections and all of their pathways that are involved. So we'll try and simplify this with the help of few stories and few images here and there. So let's get going. How have I decided to cover transplant immunology is in two parts. First, we are going to consider what are all the things that we are going to have pre-transplant. What are all the things that I'll be doing before a transplant is done? And then we'll be going ahead and talking about what are the things that we do once a transplant is done. What are the complications that a person can have post-transplantation? So let me start off with the pre-transplant story. The first question coming to everyone's mind is, what transplant are you going to do? So what are the different type of grafts? And all of us know that this graft question is a very, very important question that you have. So it's a very important PYQ. What are the types of grafts? Very simple. See, first and foremost, if you're doing an autograft would mean that from my own body, I am putting a graft to my own body. Auto means self, right? So now, for example, there's a person who suffered from burns. There is burns on the face, and the person, because of cosmetic reasons, wants that the skin should be, there should be a grafting of the skin done. So where do I take the skin? I can take the skin maybe from the thigh or from any other part of the body which has the similar kind of a texture of the skin that is present on the face. So basically, I'm doing from one part of the same person to the same person. So when it's happening in a self condition, from the same person to the same person, that is going to be auto, self-grafting. What is iso? When I say I for iso, I have learnt it as twins. So I have learnt I for identical twins. I for identical twins. That is how I have learnt isograft. So grafting that occurs between twins is known as isograft. Now let's talk about allograft. Allograft is going to be of the same species, and xenograft is going to be between different species, means same species. So like, for example, we guys study so commonly there's a kidney transplant, or we talk about a bone marrow transplant. So all these obviously happen from human to human. Whatever is happening within the same species. It is happening from human to human, that is allograft. Whereas when I say xenograft is something from a different species. So very commonly you must have heard of a prosthetic heart valve being put in. So prosthetic heart valve is something that you get from different animals. There are porcine, bovine, different type of heart valves that are obtained, and they are put in the humans. So basically from an animal who's a different species, it is being put in a human who's a different species, and that is known as a xenograft. Let's do a recap over here, guys. When I'm talking about autograft, auto means self. Isograft, I for I, identical twins is how I have learnt it. Then difference between allo and xeno. So allo is between all the people are the same. All the people are the same means same species. And xeno means this is happening between different species. These are the types of grafts which you have to know. Very, very important. Now let's understand what am I going to do once a graft is ready. Once I know that, okay, I have to do a kidney transplant or a bone marrow transplant. What am I going to do prior to it? So there are two things I do. One, I have to match the blood group. So I do ABO matching, that is happening between the donor and the recipient. That is one criteria that I have to fulfill. The other is HLA matching that I have to again do between the donor and the recipient. So now, I hope all of you remember the HLA, different genes and the different parts of an HLA. Do you remember HLA A, B, C, DP, DQ, DR? All of this we've done in the initial part of immunology. So please note that when I'm talking about HLA matching, what is the criteria that we follow? So you must have seen certain percentages being given. Like they say that for a bone marrow, there should be 100% matching that you have to go for. In kidney, even with 50% matching, you proceed. So you'll say, ma'am, you mean to say that even if 50% matching is there, then also you're going to proceed, then the transplant is going to fail. Because please remember, I also put the patient on certain immunosuppressive drugs. I also put the patient on certain immunosuppressive drugs, and that basically means that the immunity of the patient or the recipient or immunity is also going to go or going to be suppressed so that the transplant is not rejected. So remember, for bone marrow, I target 100%. For kidney, I try to do with a 50%. For cornea, even with a 0% matching, I can proceed. Why? Because cornea is an avascular structure, and even without matching, I can proceed for a cornea transplant. What are the next? The heart, the liver and the lung. Now these organs, don't they need a HLA matching? They do. Of course they need an HLA matching, but I am always going to keep something above the matching for them. Means I'm always going to consider about their vitality. Their vitality shall always be my prior and my first and foremost concern. Why? Because just imagine, especially for the heart and the lungs, you don't get these from living patients. This is an organ, heart and lung, you will get once someone has died. Now someone has died, I've got a heart in my hand. Should I wait that first I will match this heart with my recipient? I will wait for the report for 1 or 2 days. By that time, that heart is not going to be vital anymore. So my first concern in such cases is vitality. Vitality or viability comes first. I have to make sure that even if it's, I've got a heart and I have a patient who's in need of it, by managing the patient with immunosuppressive drugs and even without an HLA matching, I should be able to go ahead with that transplant. So remember, these were rules for few organs. So for bone marrow, 100%, kidney 50%, cornea, avascular 0%, and for main organs like heart, lung, liver, viability is my first priority, then comes matching. But what exactly am I doing in matching? What all am I considering out here? Please note, for HLA matching, we have certain book criteria that are mentioned. So for adults, first I'll tell you what is the ideal protocol. And then I'll tell you that for adults, what is practically being done. See, sometimes all that's written in the textbooks is not that is being performed. You know that. So first, let me say that what are the genes that I'm targeting? HLA, A, B, C, DQ and DR. HLA, A, B, C, DQ and DR is what is being matched. So how many genes are being matched? Can you count for me? I have 1, 2, 3, 4, 5. I want all of you to go back to your basic genetics and understand that whenever you have a gene, every gene can have two forms. Like for example, if there is a gene, it will always have capital A and small a, dominant, recessive. So basically these are alleles. Every gene has how many forms? Capital and small, two forms. What are those forms known as? Alleles. Every gene has 2 alleles. So over here, when I was talking about a total of how many genes? 5 genes. How many alleles am I matching? I am matching a total of 10 alleles. That is what is the question in the previous years. That is, an ideal matching in the adults comprises of how many alleles? You have to do a 10 matching. But what is the criteria? Minimum, how much are you going to target? So please remember, you are going to target a minimum of 8 by 10. So what is the criteria that you have to follow? The criteria that you follow is going to be minimum 8 on 10. But that is only going to be a case of your ideal matching. What is in practical? We have HLA, A, B, C and DR. Basically, I cut out the DQ. I'm going to cut out the DQ. That is what I do. So what am I left with? I'm left with A, B, C and DR. So how many genes do I have now? Can you count for me? We have 1, 2, 3, 4. If I have 4 genes, how many alleles do I have? I have a total of 4 2s are 8. I have 8 alleles. What is going to be the criteria? The criteria is having matching of at least 6 on 8 if I have to proceed with the transplant. But if you realized, I was only talking about adults. What about children? What is the protocol for children if a transplant has to be done? So C में C you're going to remove. In C there is no C. Basically now I'm going to remove the C. So I'm left with what? A, B and DR. I'm left with A, B and DR. So HLA, A, B and DR is what I'm going to match in children. So can you count how many genes now? 1, 2, 3. 3 genes means how many alleles? I've got a total of 6 alleles. What is the cutoff going to be? The criteria says at least 4 on 6 should be there. So did you realize all this while, whatever was the denominator, that is the total that you are matching, but the criteria was 2 less than the denominator. So if your criteria was matching 10, you should have at least 8 on 10. If your criteria was matching 8, you should have at least 6 on 8. If your criteria was matching 6, you should have at least 4 on 6. So basically your numerator criteria is always 2 less than the -2 of the denominator. Remember, in children, who is the only one who gets a perfect 6 on 6 match? Who is the only one who gets a perfect 6 on 6 match? And that is going to be identical twins, or those are going to be Identical twins. Please remember, other than these, no one else can get a perfect 6-on-6 match. Very, very essential. I hope everyone's okay with this. Can we move forward? Overall, ideal 10, 8 on 10 is the criteria. Practical 8, so 6 on 8 is the criteria. Children 6, so 4 on 6, -2. But out of these, if someone asks you which is the most important HLA gene that has to be matched, doctors are the most important. So please remember, the most important matching is DR matching. The most important matching is going to be the DR matching. That is doctors. That is how I have learnt it. Doctors are the most important. On that note, we are done with two things. What needs to happen before a transplant? ABO and HLA matching has to happen. So that is done. You say we've got a perfect match, or whatever I was targeting, my criteria has been fulfilled. You've done the transplant. Now, what are the problems that can come to you in the next phase? What is going to happen post-transplantation? So post-transplantation, there are two issues that can come up. Either there can be transplant rejection, or there can be GVHT. Now, most students don't understand the difference between the two. So what I'll do, I'm going to draw a particular recipient over here. So for example, this is a recipient, right? And in this recipient, you have placed a kidney. Okay, very funny looking man. But you have placed one kidney in this person. This is one situation. But this person says, no, I don't accept. It's like a proposal. Just remember, it's like a proposal. So let's imagine you have a boy, and the boy has proposed one flower to the girl, proposed with one flower to the girl, but the girl says, no, I reject your proposal. I am not going to accept, and throws the flower away. So basically, the girl is attacking and has thrown the flower away. It has rejected. So can I say the girl or the recipient is going to reject the donor graft? The recipient is going to reject the donor graft. That situation is known as a transplant rejection. So a boy proposing to a girl, but the girl says, I don't want this rose, and throws it away. So that is a rejection. Other scenario is, now I have the same proposal story that is gonna come up in front of you. Again, over here, you've got a kidney that you've placed. Again, a proposal has been given to the girl. This time the girl accepts it. But that boy who had given a proposal, who had proposed to her, that boy ended up being a bad boy, ended up being a bad man. He ended up doing damage to her. So who is attacking? The boy, the donor. This time, the donor is going to attack the recipient. So this is a toxic relationship. That is how we are going to learn transplant rejection versus GVHD. Repeating once again, when I'm talking about transplant rejection, the girl rejects the proposal. The recipient has rejected the donor kidney. Recipient says, I don't accept this kidney. But in GVHD, what happens? The recipient has accepted. Recipient said, okay, I accept your proposal, but this boy ended up being toxic. He ended up attacking her. So this is a toxic relationship. That is, the donor attacks the recipient. That is known as GVHD. What is the full form of GVHD? Graft versus host disease. It's a toxic relationship. A war has started. Graft versus host disease. This was a very basic. Let me get into a little more details. Let us start one by one. Starting with the first one, that is transplant rejection. I will be teaching you three types. There's something called hyperacute rejection happening very, very quickly. So just imagine, what was transplant rejection? Transplant rejection was to do with the girl rejecting the proposal. You have rejected the kidney, thrown the kidney away. So how much time will you do it in? If you do it very, very quickly, if the girl rejects it within 48 hours, she's within 48 hours, or on the spot she says, I am rejecting your proposal, that is hyperacute rejection. If the girl thinks for few days and weeks, and then rejects the proposal, that is acute rejection. But if she thinks for many weeks and months and then rejects your proposal, that is chronic rejection. This is basically friend zone, that she kept thinking for many weeks and many months, and after that she friend zoned you. That is what is chronic rejection, which you see most commonly. Friend zoning is one of the most common things that you notice, right? So which is the most common rejection that you'll have? The most common is chronic rejection. So let us repeat. Hyperacute is what? Hyperacute is going to be the rejection that has happened very, very quickly. The rejection that has happened happened very quickly within the first 48 hours. Next, if it's acute rejection after few days or weeks, but if it happens after many weeks or months, she has friend zoned you and rejected you, which is the most common, that is chronic rejection. And you will now realize that I will link this with hypersensitivity, because if you remember, when I was talking about hypersensitivity, I promised you that I will explain the hypersensitivities of transplant rejection, and now we'll study them one by one. So let's take them up. Let us first, guys, take up the very famous hyperacute rejection, the rejection that has occurred very quickly. What did I tell you? What is the definition of hyperacute? The donor has been rejected, the donor kidney or the donor graft, or most of the places I'll take kidney transplant example as an example, okay? So donor graft has been rejected within 48 hours, and that is 48 hours is also upper limit. This is like the girl, you went to the girl and proposed to her, she has basically rejected you on your face. Very sad situation. But remember, most of the times it is on the OT table itself. You don't even have to wait for 48 hours. It is going to be rejected on the OT table itself. Have you wondered why? Just imagine, if you go and propose to a girl, why will she reject you on your face? Because she already has a relationship earlier, she already is with someone else earlier. So this means the reason for this hyperacute rejection is already there were some antibodies present. She already had a prior relationship. So she's saying, I'm already in a relationship, so I can't accept you. She's rejected you on your face. Very sad story. So that is known as preformed antibodies. So now let's understand. The story is clear, but we need to understand the logic behind it. So for example, you placed this kidney, and along with the kidney, of course, you tried to anastomose the blood supply also. This is the kidney that you've placed. So I'll label this as the donor graft. Now, the recipient says, I am not going to accept it. I am going to reject it on the spot or within 48 hours. Why? Because the recipient says that I have some antibodies in my blood. I have some preformed antibodies in my blood. These preformed antibodies are going to go. They are going to damage whatever this blood supply you have tried to create. That also they will damage. Whatever this kidney that you have got, that also they will damage. So these antibodies will go and damage everything. So think logically, who will have an antibody? Either someone who has undergone many previous multiple blood transfusions, either that person, or it is going to be a multiparous woman, a multiparous lady, a lady who's given birth to a lot of kids. She will also have a lot of antibodies. So two situations, either the person is having many blood transfusions earlier, so he's developed a lot of antibodies, or it's a female who's had many babies earlier, so she's developed a lot of antibodies. The concept is those antibodies were already there in his or her blood. As soon as you kept this kidney, the antibodies went and attacked this particular kidney, the blood vessel also, and the kidney also. And before you feel that you'll have to mug it up, let me take you into your general concepts. Tell me one thing, guys. What is the necrosis that happens in the blood vessel? And what is the necrosis that happens in the kidney? Think logically. Kidney is what organ? Kidney is a solid organ. So which necrosis happens in a solid organ? Coagulative necrosis. Blood vessel में कौन सा necrosis होता है? Fibrinoid necrosis. So exactly what I'm going to teach you next. What are the changes that you would get to see in this donor graft kidney? The donor graft, what necrosis will it show you in the blood vessels? In the blood vessels, it will show you fibrinoid necrosis. What necrosis will it show you in the kidney? Kidney is a solid organ, so it will show you coagulative necrosis. And what was the definition of necrosis? Is necrosis always associated with inflammation? Yes, necrosis always shows you inflammation. Was it difficult? If you had your basics in place, it was so simple. So now let's repeat it once again. Because these antibodies have gone and attacked the kidney, in the blood vessels, we have got the fibrinoid necrosis, because fibrinoid necrosis always happens in the blood vessels only. Now we talk about what happens in the kidney. Kidney is a solid organ, so solid organ is going to have coagulative necrosis in the kidney, right? And now I know for a fact that all necrosis are associated with inflammation. So this patient also shows, or this graft will also start showing inflammation. But have you ever wondered, how will my surgeon get to know all this? To pathologist is seeing. How will the surgeon who's operating on the OT table get to know that, oh my God, this kidney has been rejected? He can't see all this under a microscope, na? This is later part that the pathologist will see. How will the surgeon make his decision? Because the surgeon will realize that the kidney has become extremely Floppy means I have put the kidney in the patient, but the kidney is very loose. It's not taking up any tone. If it would have been properly transplanted, it would have become very tight and with a lot of tone. But it's very loose, one thing. Second, the kidney has suddenly turned very, very blue. So now, why is the kidney suddenly turning very blue? Because it has not got blood supply. Everything is dying, all necrosis is occurring, so it's becoming very, very blue. And also there will be realization that few drops of bloody urine will start coming out. So they realize that there is bloody urine that starts coming out. So basically there are few drops of urine or blood in the urine, few drops of blood in the urine that you are going to see. As soon as the surgeon sees this, he's doing the surgery, he's doing the transplant, he sees the kidney has suddenly become very, very floppy, loose, blue with blood in the urine. So blood, blue and loose, blood, blue and loose. As soon as you see blood, blue, loose, you know the kidney has not been accepted. It is a hyperacute rejection. So just 3 questions. Question number 1, hyperacute rejection ka cutoff, that is within 48 hours. The reason for hyperacute rejection, preformed antibodies. How is the surgeon going to get to know it? That is, if it is blue, loose and blood, blue, blood and loose, so that surgeon knows that now the kidney has not been accepted. How does the pathologist get to know it? Necrosis, fibrinoid necrosis, coagulative necrosis, and there is the picture in front of you. You can very well see that yes, this is a kidney and it's showing you very pink. When everything becomes pink means there is an element of necrosis that is going on. So all around, if you notice, everything has become all pinkish, dead cells, no nucleus, dead cells, matlab this is necrotic cells. Hyperacute rejection done. Should we move on to the next one? So before that, tell me, was hyperacute rejection all to do with antibodies? Antibodies were coming and attacking. So which hypersensitivity do you want to label it under? Type 2, because type 2 was antibody mediated. So hyperacute rejection is type 2. Now I go on to the next one, that is acute rejection. Acute rejection, as I can see, is going to be a combination of 2 and 4. Can you guys try to decode? 2 was to do with antibodies. Okay, antibody matlab humoral, something humoral is antibody. 4 was the only hypersensitivity to do with cells. So this is the cellular hypersensitivity. So can I say acute transplant rejection, the one that occurs within many days to weeks, the rejection, the proposal is rejected after many days to weeks, is actually a combination of type 2 and type 4 hypersensitivity. Type 2 means it is to do with antibodies, so it is acute humoral rejection, and type 4 is to do with cells, so that is known as acute cellular rejection. Now I need to go into the details of these and understand what is happening in both these situations. So in acute humoral, you will focus on antibodies. In acute cellular, you will focus on the cells. So in acute humoral, please note the kidney that has come. The kidney that has come, will that have its own antigen? Some donor, some person has his own antigens. So the MHC1 and 2 of this kidney, the MHC1 and 2 of the kidney will start acting as antigens for the recipient. These are going to act as antigen for the recipient. So, jo donor kidney ka, that is what you say, the donor's kidneys, MHC1 and 2 start acting as an antigen for the recipient. Will you start making antibodies? Yes, this means there is going to be an antigen-antibody complex that is formed. Immune complex is formed. What happens when an immune complex is formed, guys? When an immune complex is formed, we tend to activate the complement system. We tend to activate the complement system, and complement system means what? There is a complement protein that comes and gets deposited, that is known as C4D. And why is this slide looking so brown? Because when I say brown in pathology, we mean to say there is immunohistochemistry that has been done. So please note that I can see that there is a brown color that is present around the capillaries and over here and around the capillaries over here. So because it's around the capillaries or the vessels, we call it rejection vasculitis. We refer to it as rejection vasculitis. So repeating once again, please note that again we'll write it. When do I call it acute humoral rejection? I call it acute humoral rejection whenever there is a donor kidney. Whenever there is a donor kidney, that kidney tends to carry its own set of MHC, MHC1, MHC2, and this will act as an antigen. This is going to be an antigen for the recipient. So the recipient will say, fine, if you're trying to put an antigen inside me, I will start start making antibodies? I will basically start making immune complexes. And because of the formation of this immune complex, there is activation of complement. And because of the activation of complement, there is going to be what deposition? There is going to be C4D deposition around the vessels. This is the hallmark or the marker of this event, because this is referred to as rejection vasculitis. This is referred to as rejection vasculitis. Please note, very, very important. They will ask you a simple question for acute humoral rejection. What is the main marker that you have? It is C4D. They will show you this immunohistochemistry. Very, very important. All these brown colors. That was of acute humoral rejection. I'll write it in one word. I will just write C4D over here. I will write C4D for acute humoral rejection, or in other words, I will write it as rejection vasculitis. Simple. That's your take-home message. Now let's talk about acute cellular rejection, because in cellular rejection, I'm going to talk about cells, CD4, CD8 and all of that. So please remember, जो donor kidney का antigen presenting cells है, whose antigen presenting cells are doing a problem? The donor's antigen presenting cells, they are going to present the antigen to my CD4 and CD8 cells, or to the recipient CD4 and CD8 cell. Simple. We've already studied this in general immunona, that जो donors antigen presenting cells are there, or whatever antigen presenting cells in general, don't they present the cell either to CD4 or to CD8? Have we studied this? Yes. So this time, whose antigen presenting cells are presenting? The donor, the kidney that has been put, that has got its own antigen presenting cells. That is going to present the antigen to the CD4 and the CD8 T cells of the body of the recipient, resulting in what? So much of CD4, CD8, so much of inflammation. This is going to result in tubulitis and endothelitis. This is going to result in tubulitis and endothelitis. Let us recap. Itis, tubulitis and endothelitis. So for example, over here, you can actually see that there is a tubule that I have labeled for all of you. There is a tubule that I have labeled for all of you, and you can see all the tubule has those blue color cells, which is fine. But I want you to be very cautious. Can you see, ek to apna, there is a routine, every tubule has nuclei. So yeah, there are routine nuclei. But other than that, can you see some very chota small, really tiny lymphocytes, really tiny dark lymphocytes? So where are they coming from? There must be some kind of inflammation. This basically refers to tubulitis. These white things that I have marked, they are all the itis, they are the lymphocytes. Whereas what is the next aspect? The next aspect is known as endothelitis. The next aspect is endothelitis. So when I zoom into this, firstly, endothelitis means I'm talking about a blood vessel. When I'm talking about a blood vessel, I can definitely see that this is a blood vessel. Why? Because I can see red blood cells inside it. I can see red blood cells. So yeah, this must be a blood vessel. First, let me find out the endothelial cells. So the big cells are the endothelial cells. Fine, I found out the endothelial cells, but my focus is on itis. My focus is on endothelitis, the inflammatory cells. So can you see the dark blue color dots? Everywhere the dark blue color dots are going to be the lymphocytes. So these dark blue color dots are nothing but endothelitis. What are we talking about? We are talking about acute, which rejection? If lots of lymphocytes are there, acute cellular rejection is being spoken about. So repeating once again, acute cellular rejection was why? Firstly, which cells of the recipient have been activated? Both CD4 and CD8 have been activated. By whom? By the kidney that came into the body. So please remember, this particular pathway is also indirectly known as the direct pathway. This pathway is also known as the direct pathway, because I'm going to tell you one more, indirect. So you will always have a confusion. So how I have learned is, in the direct pathway, who is creating a problem? My own antigen presenting cells are creating a problem, or the donor's antigen presenting cells are creating a problem from me? So direct mein D. It is the donor's antigen presenting cells which are creating a problem and activating. So D for D. In the direct pathway, the donor's antigen presenting cells create a problem, because you have finished with acute transplant rejection. Now you need to go on to chronic transplant rejection. Remember, chronic was the friend zone. Let me show you that slide once again so that you have a little bit of orientation. Remember, I told you this happens very, very, very late. It happens after many weeks to months. It is like friend zoning a person, and it is the most common type of rejection that you have. But it is all to do with cells. When it is all to do with cells, which hypersensitivity will you call it? If it is all to do with cells, you will call it type 4 hypersensitivity. So now I can explain this to you, that over here, or when I'm talking about chronic transplant rejection, and I know that it is type 4 hypersensitivity, and I know that this is going to be mediated by cells. So again, I'm going to activate the cells, but this time my own antigen presenting cells are going to create a problem. Self antigen presenting cells are going to go and activate only the CD4 T cells. Did you wonder and did you notice right now that in the previous one, that was also acute cellular and this is chronic cellular. In acute cellular, I was having a problem with the donor. The donor APCs coming into my body were creating a problem. Over here, my own APCs are creating a problem. But there's a difference that you see more. When the donor APCs were creating a problem, they were activating both CD4 and CD8 T cells, because donor antigen for me is totally foreign. I have never seen that antigen, so that will come and activate every cell of my body. Whereas when I'm talking about my own antigen presenting cells, I think by now you guys have that concept. All antigen presenting cells of our own body have which MHC on their surface? They have MHC2. Go back to your general basics of immunology. All the antigen presenting cells have MHC2. MHC2, remember the rule of 8. MHC2 presents to what? MHC2 will present to CD4 T cells, because 2 4s are 8. You had to come up to a total of 8, right? So remember, MHC2 is going to present it to the CD4 T cells. That is very, very important point that you have to know. So now I realize that when the donor's antigen presenting cells were coming, they were not following that CD4 CD8 rule, because donor ka cells matlab they were automatically coming from outside in my body and everything was getting activated. But when my own antigen presenting cells are coming into play, they will only activate the CD4 T cells. And what will that result in? What are the features that you see? So please remember that I know for a fact that CD4 T cells or type 4 hypersensitivity, I have just written the entire pathogenesis once again. CD4 T cells are going to differentiate into what cells? They shall differentiate into T helper 1. Do I already know that T helper 1 cell releases which interferon? It releases interferon gamma, and G for gamma, G for granuloma. So when I've written epithelioid cells, this basically means that there is an evidence of granuloma formation, and this is all that are studied in type 4 hypersensitivity. I hope you guys remember your type 4. Type 4 mein same ho raha tha. You were having the CD4 helper cells, T helper 1 cells releasing interferon gamma, G for G. Gamma was causing granuloma, and this hypersensitivity is complete. So whenever this happens, what is exactly going to happen to the kidney? There is going to be GOTI that happens to the kidney. So remember, when chronic transplant rejection occurs, there is GOTI. What is GOTI? The glomerular basement membrane duplicates. This is something you'll have to do ratta. You're not going to get pictures of it, but yeah, you'll have to at least learn it from the point of view of theory. So first is, think of all the things that you have in the kidney. Let me highlight all the things that you have in the kidney. So you'll say, number one, I have the glomerulus. What happens in the glomerulus? The glomerular basement membrane undergoes duplication. So एक problem glomerulus का हो गया. Other than the glomerulus, in the glomerulus you will say I have a lot of capillaries, I have a lot of blood vessels. So what happens in the blood vessels? That is the next part. There is obliteration or sclerosis of the blood vessels. So blood vessel also affected. What else do you have? Then you have PCT, DCT. You basically have the tubules. What is happening to the tubules? T. That is going to be tubular atrophy. To the tubules, you have tubular atrophy. And finally, what is it that you have in between? In between everything, you have the interstitium. Interstitium undergoes fibrosis. Interstitium undergoes fibrosis. Now you understand how did we make that come to that GOTI mnemonic? If you know the 4 parts of the kidney, everything is having one problem. Glomerulus mein kya hoga? The basement membrane duplicates. What happens to the blood vessels? They are obliterated. What happens to the tubules? They are atrophied. And what is happening to the interstitium? That shows you fibrosis. that is the concept behind the chronic transplant rejection. And you know what chronic transplant rejection is known as? It is known as the indirect pathway, because whose APCs were creating a problem? My own APCs were creating a problem. So remember, there are two pathways. When I'm talking about cells, I'm not talking about the antibody wala pathway. I'm talking about the cellular pathway. Whenever I'm talking about the cellular pathway, please remember there is a direct cellular pathway and an indirect cellular pathway. Direct mein who is going to create a problem? My APCs or donor APCs? Direct mein D, the donor APCs create a problem. That is going to be acute cellular rejection. So remember, in the direct pathway, when the donor APCs create a problem, that is going to be the acute rejection that we have. Whereas sab kuch ulta, when I talk about instead of direct, I talk about indirect pathway. Instead of donor APCs, I talk about self APCs. And instead of acute rejection, I talk about chronic rejection. So that becomes the other pathway. I know it's still tough. Before I move on to the next, I know the next topic is GVHT, but I want to skip that for the time being and give you a one slide summary of all the different rejections that you have. First and foremost, and with this try to answer with me, there is a hyperacute rejection, the second one is acute rejection, and the third one is chronic rejection. Let's do their timelines. Hyperacute rejection is very, very quick. It is going to happen within 48 hours or mostly on the OT table. Acute rejection takes a few days to weeks. And chronic rejection, remember the friend zoning criteria? That was the weeks to months, and unfortunately friend zoning is the most common. So chronic rejection comes across as the most common rejection. What were the hypersensitivities? Remember, hyperacute was hypersensitivity 2. Chronic was hypersensitivity 4, and jo center wala hai, that is both. That is going to be hypersensitivity 2 and 4. Whenever I talk about hypersensitivity 2, I have antibodies. So what was happening in hyperacute rejection? The patient had preformed antibodies. The preformed antibodies were either because of blood transfusion or was because of multiparity. I hope you are with me on this. The previous antibodies were because of blood transfusion or multiparity. What was the kidney becoming? The kidney was going to become very, very blue. It was going to become very, very loose or floppy. And what was going to happen? There was going to be blood in the urine that the surgeon was going to see. What were the necroses that we were going to see as a pathologist? So remember, microscopically we see two necroses. The necrosis in the kidney is known as coagulative necrosis, and the necrosis that happens in the blood vessels is going to be fibrinoid necrosis. I hope everyone has been able to make this story up till now. Let's move on to the next one. When I talk about acute rejection, and acute rejection is two types, that is 2 and 4 hypersensitivity. The 2 hypersensitivity basically means it's a humoral antibody wala rejection, and 4 tells me it's a cellular wala rejection. So for antibody wala rejection, I ended up making a complement protein. What was the hallmark? The hallmark was C4D around the blood vessel. So this is what you called as rejection vasculitis. This is what you called as rejection vasculitis. Whereas when I talk about cellular mein you had, again, this is also cellular. So abhi I'm talking about acute cellular. Whose APCs will create a problem? That dad mnemonic should come to your mind. Donor APCs will create a problem, means direct pathway I'm talking about. That is acute cellular rejection. So here I will say the donor APCs are creating a problem. This pathway is also known as the direct pathway. And what is it going to result in? This will result in tubulitis and endothelitis. Tubulitis and endothelitis. Coming to the last one is chronic, the friend zoning, and it is hypersensitivity 4, means it is only and only cellular. But what cellular? Direct pathway, indirect pathway, donor APC, self APC. So you said donor APC and direct pathway was in acute, which I have already written here. Now the story is different. Over there it was acute, here it is chronic. Over there that was direct pathway, now I'm going to write it as the indirect pathway. Over there it was the donor APCs which were creating a problem. Here it is going to be self APCs which create a problem. And what will the patient suffer from in the kidney? The kidney is going to have GOTI. What is GOTI? All the 4 types of the kidney problems that you know: glomerular basement membrane duplication, obliteration of the blood vessels, tubular atrophy, and interstitial fibrosis. Finally, with that, I know it's not very, very simple, but this is your final go-to flowchart that I have made for all of you for your transplant rejections, only transplant rejections, because now I am ready with GVHD. Now we can take up the graft versus host disease. Do you remember what was graft versus host disease? Who was rejecting whom? No one was rejecting. The proposal was accepted, the kidney was accepted, but this kidney ended up being a toxic relationship. So can I say the kidney was the toxic one? The donor graft is going to go and attack the poor recipient who took the proposal. The donor graft is going to go and attack. So remember, it's the kidney who is going and attacking the human being, or is going and attacking the recipient. Why? The one who attacks is always stronger. So the donor is basically immunocompetent, and the one who takes the attack is always weaker. So there is going to be recipient which is immunocompromised. Repeating once again, the donor that you have is going to be confident and competent. He has lots of immunity. That is why he's attacking. And my poor recipient does not have too much of immunity. My poor recipient is compromised. So now, how many types of GVHD do we have? GVHD is of two types. One is going to be acute GVHD and the other is chronic GVHD. So see, in the previous one, when we were talking about acute, chronic and all of that, I did not have any proper timeline. I used to say weeks to months, months to days, all that. But here in GVHD, I have a proper timeline of 100 days. If it happens within 100 days, it is acute GVHD. And if it occurs after 100 days, it is going to be chronic GVHDs. Less than 100, more than 100 is the final cutoff criteria. And what is going to be affected? The cell organs are affected, means the skin is affected, the intestine of the recipient will be affected, and the liver is going to be affected. So what is going to happen? The skin is going to come up, patient is going to come up to you with a rash. Next, the patient is going to come up to you with diarrhea, because intestine is involved. The patient is going to come up to you with jaundice because the liver is involved. But that is all acute. Starting mein to simple hai. The skin will show you a rash, intestine will show you diarrhea, liver hai to jaundice. But as it becomes chronic, you are going to see that the skin will start showing you fibrosis. Skin will start showing you fibrosis. The liver will start showing you fibrosis. Fibrosis basically means a lot of nodular cirrhosis wala thing will start. And intestine is what? Fibrosis in the intestine is what, guys? It is stricture formation. Intestine will start showing you stricture. So basically the word chronic refers to lots and lots of fibrosis that is going to happen everywhere. But the question that they ask you is, what are the three main organs affected in GVHD? Remember it as it is. They will give you some random fourth organ which is not affected. It is skin, intestine and liver. So remember skin. Number one, the largest organ of the body, that is skin, is affected, and the entire GI tract. So GI tract will have intestine also, GI tract will have hepatobiliary also. So pura GIT is affected and the skin is affected. That is what happens in graft versus host disease. So I hope everyone has understood that there are two things. Either we will reject the kidney or the kidney will attack me. If we reject it, that is rejection. If the kidney comes and attacks me, that is known as GVHD. Everyone sorted with this? Now coming to the next question. If the person is creating so much of problem, if the kidney that is coming into my body, like in GVHD, is creating so much of problem, should I suppress it from beforehand? Should I treat that kidney which is, for example, if this is a kidney, this has to be kept in my body. I know this kidney is going to create a lot of problems. Should I automatically suppress it? Ideally, you would say yes, but my answer to that is no. A big no. And why is my answer no? Because these T cells which are coming into the body are coming for a reason. So just imagine, forget transplant, think of gynae, think of obstetrics, think of pregnancy. Whenever a sperm and an ova fuse, don't they have to implant first into the uterus? They have to catch on to the uterus, implant in the uterus. Same way, whenever a graft is going to come, the graft has to basically attach on to the recipient. The graft has to basically get accepted. The graft has to make a place for itself. That is known as engraftment. And you know who does that engraftment? Engraftment is done by the donor T cells. Engraftment is done by the donor T cells. So these donor T cells till now were looking quite villainous and quite like a villain and a bad man in the story. But I realized that one advantage of them is that they are going to do engraftment. So I can't suppress them. They are going to help in making a place for that kidney. I can't suppress them. Secondly, just think, say it's a bone marrow transplant. Why would you do a bone marrow transplant? What is your patient suffering from? You'll say, ma'am, my patient was a case of blood cancer. My patient was a case of leukemia or a blood cancer. So, you know, these are all blasts. These are bad cancer cells. These T cells which are coming from outside, they are normal. They are normal means they will actually help in killing these bad people. So can I say that there is something known as GVL, graft versus leukemia? That means that the T cells have a property that they will help in killing the leukemic blasts. They will help in killing the bad men in the recipient. So now I realize that in all those rejections, I was making the T cell as a big villain. But now I realize this T cell has two very important properties. Number one property is engraftment. It will help in making a place for the graft, be it a kidney or a bone marrow. Second is, it will actually fight. It will come and it will start killing all the bad people. It will start killing all the leukemic blasts, and that is known as GVL, graft versus leukemia. I hope everyone's okay with this. No confusion. All good. All said and done. Now moving on to the next thing, that what are we going to do in terms of a complication? What are otherwise the complications that can occur? Not just rejection and GVHT, infections. So what all infections can happen? I think everyone knows cytomegalovirus infection is very common following, say, transplant of the bone marrow, transplant of the kidney. Then there's something known as BK virus. BK virus. Now, what is BK virus? BK virus belongs to a DNA virus family known as the polyoma viruses. It belongs to the polyoma virus, which is a DNA virus family, and I have learnt it as bad kidney. Bad kidney matlab this is going to make the kidney very bad, and the urine microscopy shows you some very important cells known as the decoy cells. The urine microscopy shows you very important cells, decoy cells. Other than that, not just infections of the kidney. Overall, I realized that because of transplantation, the patient is going to be in an immunosuppressive state. The patient is going to be in an immunosuppressive state. So, immunosuppressive states में what can happen? Human papilloma virus infection can happen, Epstein-Barr virus infections can happen, HHV8 infections can happen, and we all know the conditions associated with them. Human papilloma virus matlab which cancer can it cause? It can cause cervical cancer. Epstein-Barr virus can cause all the lymphomas. Human herpes virus 8 can cause Kaposi sarcoma. So whatever you have read about these viruses in your microbiology, virology chapter, and even in pathology, all of those infections can happen. Problem being that in a post-transplant situation, my patient is in an immunosuppressive state. So basically treating these kind of, like you have opportunistic infections in AIDS, AIDS is also immunosuppressive. Same story over here you're putting up. Easy, sorted, big sigh of relief, transplantation is done. Your go-to 2 slides. Remember, this is the first slide which summarizes all the transplant rejections. This is the second slide which is going to summarize your GVHT. These 2 are going to be your last day revision for sure. Let's practice a few questions. Question number 1. What is a graft between members of the same species termed as? Same species, all of the same species. All of the same species means we are going to have allograft. What was autograft? Autograft was self-grafting. I for I, isograft was to do with identical twins. Then allograft is what? Allograft is going to be same species between human to human, and xenograft is going to be different species. Xenograft is going to be different species. Moving on to the next question, which is definitely a little tougher one, but I think let's try. We've done so much of detailing. Let's see if we can, have a little bit of hang over, a good hold over our questions. Which of the following histological changes is suggestive of Chronic transplant rejection. Don't read the options. Apna socho. Okay, chronic. Chronic was that friend zoning story. Type 4 hypersensitivity. Okay, type 4 means it was all to do with cells. And what were you see microscopically? Microscopically, you were seeing goatee. These are my points that I have made in my mind. Now let me start reading. Option 1. C4D positivity is seen in the capillaries? No. C4D was a marker of acute humoral rejection. Acute humoral rejection is going to have C4D marker. So, ye to hai wrong statement. Look at the last one. Inflammatory cells around peritubular capillaries, basically they're talking about tubulitis. And in the third option, inflammatory cells in the glomerular capillaries, they are talking about endothelitis. Endothelitis and tubulitis were features of acute cellular rejection. They were features of acute cellular rejection. So they are also not over here. I have been asked about chronic rejection. Chronic rejection is GOTI. G for glomerular basement membrane duplication. Do I have that option? Yes. Glomerular basement membrane duplication means double contour. So that is the answer that we have over here. All the others are ruled out. So if you know that one table, most of your query is sorted. Last question that we have. Which of the following organ is least likely to be affected in graft versus host disease? Least likely. What was being affected in graft versus host disease? The largest organ, that is skin. And the entire GIT tract. GIT tract mein matlab ek to intestine tha, and GIT also includes hepatobiliary, so liver was also affected. These were the three. So skin hai, intestine hai, liver hai. What is least likely to be affected? So least likely wala answer becomes the lungs. So what is my answer in this situation? My answer over here becomes the lungs. I hope everyone's okay. No confusion, right? And that definitely wraps up. Was the last question that we had for transplant immunology. Sorted. We are only left with